Hello everyone, this is Shu-Ting Lee, a speech and language pathologist. Welcome to Video Atlas of Cleft Lip and Palate Care. In the previous episode, we talked about home pronunciation practice for children with cleft lip and palate. In general, children's articulation development will mature at about 4 years old. Once it is found that children have articulation errors, whether there is a cleft lip and palate or not, speech and language pathologists should first clarify what is the main cause of these speech errors. Is it a structural problem, hearing problem, or articulation skills? Or is there a limitation of child development in general? A good velopharyngeal function means when we speak or make sounds, the soft palate must raise and move backward to form good closure with the lateral pharyngeal wall and posterior pharyngeal wall to separate the oral and nasal cavity. Then, when you speak, there is enough airflow from the lungs going into the oral cavity to make most sounds. However, in some cases, even after the first palate repair surgery, usually around the age of 9 to 15 months, the soft palate still can't block the nasal cavity completely, and that is called velopharyngeal insufficiency, VPI. It will result in oral airflow insufficiency or hypernasality while speaking, affecting the intelligibility of their speech. Differential diagnosis and management of velopharyngeal insufficiency can be divided into the following stages. 1. Speech and language pathologists will provide a subjective speech assessment, including analysis of articulation skills, resonance, and oral airflow during speaking, to determine whether the child's speech error is caused by structural defect or poor articulation skills. 2. If an articulation skill problem is suspected, the child will be recommended to receive articulation training and practice for different pronunciation positions and methods. 3. If a structural defect is suspected, it is recommended to have nasopharyngoscopy or video fluoroscopy to confirm the closure of the velopharyngeal mechanism and have surgery if needed. 4. 3 months after the velopharyngeal insufficiency surgery, a small number of children will not be able to speak clearly, so they will need to receive articulation training after surgery. Although surgery improves the structural defect, it cannot change the child's former incorrectly learned articulation system. In general, the overall speech assessment includes medical history investigation, oral function examination, articulation assessment, voice assessment, hearing assessment, and verbal ability assessment. Each assessment will use different tools, such as picture books, toys, etc. Then the speech and language pathologist will make a treatment plan after differential diagnosis based on the information obtained. According to each child's condition, the evaluation process and method will vary, which will depend on the professional opinion of the medical team and the experience of the speech and language pathologist. Cleft palate speech characteristics include articulation disorders and abnormal resonance. Common articulation disorders include nasal emission and compensatory articulation disorders. Glottal stop is the most common compensatory articulation disorder. Abnormal resonances including hypernasality, hyponasality, or mixed forms. Next, I will address these speech characteristics and demonstrate the exercises that can decrease the severity of these abnormal speech patterns. Hypernasality refers to the excessive use of nasal resonance when making sounds that are not nasal, such as E becomes E. Most of the hypernasality is caused by velopharyngeal insufficiency, but some is caused by mislearning, such as E becomes O. There are 2 ways to practice reducing hypernasal sounds caused by mislearning. 1. Pinch the nose. Pinch and release the nose while making sounds, such as to let children learn to control and maintain good oral resonance.
好，那老师要捏鼻子喽。1、
2. Adjust the position of the tongue, moving the tongue down or forward. Tongue down is to lower the back of the tongue with the mouth slightly open and the upper and lower teeth touching slightly, such as tongue forward is to make the tongue move forward, slightly protruding the tongue tip between the upper and lower teeth but not biting, and slightly opening the mouth, such as Nasal emission means there is air leaking from the nose when speaking. For example, becomes becomes or becomes. Nasal emission is mostly caused by velopharyngeal insufficiency, but it can also be caused by mislearning. There are 3 ways to practice. 1. Pinch and release the nose while making sounds, such as to teach children how to control and maintain oral airflow. 2. Breath holding pronunciation practice. 3. Use a dental mirror or air paddle made out of paper to learn how to control and maintain nasal airflow through visual feedback. Compensatory articulation disorders mean that due to previous or current velopharyngeal insufficiency, in order to prevent air from escaping to the nasal cavity, children compensate by using posterior and lower positions than normal to make similar sounds. The glottal stop is the most common compensatory articulation. For example,
good
becomes
good teacher
becomes
ear.
There are 3 exercises to manage compensatory articulation. 1. Change the direction of airflow. To teach children the correct direction of airflow when speaking, puff up cheeks, hold the breath, then quickly and forcibly exhale. Also, you can pinch the nose at first, then gradually reduce tactile cues.
预备，对，好棒。
2. Learn new pronunciation methods. Start with the silent stop consonant p, then try to lengthen the air h before the vowel. For example,
哈，吼，
gradually shorten the length of the air to reduce the transition time. Also, you can receive feedback while practicing by feeling whether there is a vibration in the throat.
哎，对，好，啊，我要这个，啊，换你，啊，再试一次哦，啊，啊，对，一个，预备，放，啊，对了。
3. Change the tongue position. For example,
呼气
becomes
呼气
so children can get used to speaking with the tongue in a forward position. You can also teach them to replace other consonants with d, to review different tongue positions when making sounds. Sometimes when we change the position of the tongue, the airflow in the oral cavity may also change. During practice, visual, tactile, and auditory feedback can help children with self-monitoring. You can use a mirror to let children observe their throat movements during pronunciation through visual feedback. Also, let children touch their throats when speaking to feel the instant contraction and relaxation of muscles through tactile feedback. Most importantly, let children use auditory feedback to discriminate between correct and incorrect sounds. There is no sequence to the strategies above. You can choose the appropriate practice method according to the child's specific dysfunction of speech and learning strengths. The purpose is to teach children the correct position and method of articulation, to strengthen the oral pressure when speaking, and to establish new articulation patterns to replace wrong patterns caused by previous structural defects. If there is no significant improvement after about 3 months of practice, it is recommended to seek professional advice from a speech and language pathologist and physician. Some teachers may ask, do children still need speech therapy after velopharyngeal insufficiency surgery? In general, most children's resonance and articulation can be significantly improved after surgery. However, if speech is still unclear after 3 months, it may be due to the incorrectly learned speech patterns that the children used to have and still have after the surgery. In these cases, it is necessary for the children to have further speech therapy training. Children need time to relearn and build new skills to correct inappropriate speech patterns. For most children, it takes about 3 to 6 months to have obvious progress. It requires professional teaching, a lot of practice, and patient companionship, especially from caregivers. When accompanying children practicing at home, it is important to give immediate feedback and encouragement when children make progress to enhance their motivation and confidence while learning.